the presenter I have consent obtained previously from the patient to publicly share the photographs. The content is referenced. There's no copyright infringement intended. This presentation is for teaching and training purposes, and consent for use of the photographs have also been obtained from the actual owner. So I wanted to start us off with what is an exit procedure. So in the simplest terms, it's an abbreviation for ex utero intraoperative treatment. It is an advanced delivery procedure that needs a multidisciplinary team. It's performed in very, very specific cases, and it really requires a very thorough prenatal workup, diagnosis, as well as planning. In fetal congenital malformations, very specifically those that involve the fetal airway. And this is so that we can have a strategy in which a potentially catastrophic event during delivery as a result of airway compromise can actually be converted to a very controlled procedure. It further involves supporting mother and fetus, and all of this needs to happen whilst maintaining uteroplacental perfusion for an extended period of time. During this, we partially deliver the fetus while it is still supported by uteroplacental circulation. And this is really to facilitate intervention like airway management. This could be intubation of the patient, surgical management of a neck nurse, or even transitioning to ECMO, as in congenital diaphragmatic hernias. So the benefits of an exit strategy are essentially that you are converting a potentially catastrophic birth where a poor outcome is almost guaranteed without any intervention to a far more orchestrated event that have shown markedly improved outcomes. When we look at fetal surgery as a whole, we know that fetal surgery is an accepted treatment option for certain neonatal diseases. And commonly we divide fetal surgery into three categories. Those that are minimally invasive procedures. There are other open mid-gestational procedures. And then we get to exit treatments. These are exit and OOPS, which we will discuss in more detail later on. But the great advantage of all fetal surgery is that there's an ability to correct fetal disease with fetal circulation and uteroplacental support that is still intact. If we go back historically, in 1963, was the first reported successful fetal procedure. Since then, there were numerous case reports on intubation and bronchoscopy that had been done before actually clamping the umbilical cord. And these were in patients that required intervention because of a compromised fetal airway. But we soon found that preserving uteroplacental gaseous exchange required a lot more than simply maintaining an intact umbilical cord. Skarsgård described OOPS, which is operating on placental support. And this really was where there was intrapartum laryngoscopy or bronchoscopy performed during the cesarean section or vaginal delivery before separation of the placenta. And he found that this still didn't really assure uteroplacental circulation, partially because there was no attempt to prevent uterine contraction during the procedure, and also there was a significant loss of uterine volume due to the fact that the fetus was removed from the uterus in order to instrument the airway. And all of this resulted in loss of uteroplacental circulation. So after this OOPS procedure was described, this actually stimulated the development for further novel interventions. We now have a lot better accuracy in diagnosing fetal anatomical malformations with the use of ultrasound as well as MRI. Now, the exit procedures were initially used for reversal of tracheal occlusion in fetuses with congenital diaphragmatic hernia. So during this, we needed neck exploration for removal of these tracheal clips. But you also required the maintenance of uteroplacental blood flow until the airway was secured by means of intubation. So as experience grew, it actually showed fetal and maternal hemodynamic stability could be achieved. And as such, our indications have markedly expanded for the use of exit. Prior to the development of exit, the attempts at treatment of a fetus with airway obstruction was, in essence, what we've already kind of covered, and that's this OOPS procedure. So the OOPS is important to know that it was performed before umbilical cord clamping and placental delivery during the Caesar or vaginal delivery. But as we've mentioned before, there was inadequate uteroplacental blood flow because there was no attempt to preserve amniotic fluid volume or prevent uterine contractions. So the surgical time that was established for fetal intervention with OOPS was really only about 5 to 20 minutes. And as such, OOPS evolved into our exit procedures. During the exit procedure, we have preservation of uteroplacental circulation, which enables us longer surgical times, and this is as a result of uterine relaxation and preserved placental perfusion. If we compare the two, we know that they are similar, OOPS and exit procedure, by the mere fact that the fetus is attached to placental circulation and delivery of the fetus is at the end of the procedure. But in contrast, the difference between the two is that an exit procedure converts an emergency surgery to a more scheduled surgery. And it is actually possible to conduct surgery on placental support by means of exit for up to 2.5 hours. The main principle of exit procedure is thus maintenance of uteroplacental circulation with neonatal anesthesia by controlled uterine hypertonia. And this, as surgeons, gives us time to secure fetal airway, resect a large neck or mediastinal mass, and may even allow vascular access for other procedures such as ECMO. When we look at the indications for exit, it's really summarized into 4 broad categories, of which we as ENTs are involved in the exit to airway procedures. The other procedures we've briefly mentioned, you could have exit to ECMO, exit to resection of a mass, or even exit to separation, as in the case of conjoined twins. Specifically, as indicated by these 2 blocks, exit to airway is predominantly where ENTs get involved. This might happen during reversal of tracheal occlusion. The tracheal occlusion may have been performed following clip or endoluminal balloon procedures. Exit to airway might occur when addressing fetal neck masses, specifically cervical teratomas, lymphangiomas, and a few others such as goiters and neuroblastomas. Or exit to airway may also be used when managing chaos procedures, chaos syndromes, which we will mention later. Amongst others, these include tracheal atresia and laryngeal atresia. But just to get back to some of the other indications, we can have exit to ECMO, in which they use a lung-head ratio to assess whether or not the patient will be an adequate candidate. Could be used in congenital heart disease, in children with hyperplastic left lung syndromes, aortic stenosis. Could be used in conjoined twins or other masses, especially lung masses and mediastinal masses. What's important to note is that exit does differ from cesarean section. In our Caesars, we maximize the uterine tone to prevent postpartum hemorrhage. In exit procedures, we encourage uterine hypertonia to maintain uteroplacental circulation. In Caesars, we try to minimize transplacental diffusion of our inhalational anesthetic agents to avoid neonatal depression. But in exit procedures, you actually need a very deep plane of maternal anesthesia, provided your maternal blood pressure is normal. This is to achieve a surgical level of fetal anesthesia without cardiac depression. So how is exit actually done? Well, I think importantly, there has to be a balance between enthusiasm for performing the exit procedure on our part and maternal morbidity. It involves a very extensive multidisciplinary team. And there are a couple of key factors that we have to consider in making a decision. We have to have very selective patient selection. Our preoperative planning needs to be immaculate. This includes our MDT as well as good communication between the teams. It is obviously going to be very resource dependent. The patient and the family need to be fully aware of all the risks involved, and there are huge ethical considerations. It also involves, in preparation, quite extensive antenatal imaging, especially that of ultrasound and fetal MRI. And finally, we get to our decision as to whether or not we'll proceed with the exit procedure. The multidisciplinary team is extremely important. It is usually a very large multidisciplinary team, and every team member needs to act within their scope of practice, and there has to be synchronized cooperation between all the team members. A typical team would consist of pediatric ENTs, at least 2 anesthesiologists, 2 circulating nurses, an obstetrician, a neonatologist, pediatric surgeon, 2 scrub sisters, and an echocardiographer. This is a picture of an exit team in India, where there are 21 theatre members in theatre at one time. When considering antenatal imaging, this is really to visualize the mass in relation to the entire airway, and is best done with ultrasound and fetal MRI. It can help you to actually predict which patients are at highest risk for airway obstruction. However, this is not always a given. Concerns regarding MRI on the developing fetus have not actually shown any deleterious effects. We recommend ultra-fast MRI. Prenatal diagnosis of these giant fetal neck masses, which we may need to address, are based on ultrasound and MRI. But sometimes the differentiation between different masses can occasionally be fairly tricky, even despite the imaging. It is important to note that it is still difficult to evaluate an airway and the surrounding tissues of the neck solely on ultrasound, and for that reason, you actually require MRI. Fetal MRI will give you additional information like the size, the position, and the anatomic relationship to the airway compared to ultrasound. When we finally decided to proceed with an exit procedure, we usually plan for the exit procedure on delivery when the child is term. However, the fetus needs to be very closely monitored during the pregnancy for any development or progression of hydrops or cardiac decompensation. And if this does develop as evident on ultrasound, you may need to proceed to open fetal surgery to salvage patients that are less than 30 weeks of gestation. If it's only developed after 30 weeks, the fetus should be delivered by exit. So how does the technique work? Well, as we mentioned, we need our MDT. The patient's going to need a general anesthetic. It involves a hysterotomy. It involves delivery of the baby, head and neck only, or head, neck, and torso. Very importantly, it needs airway stabilization once partial delivery is achieved. And then once airway stabilization is performed, we need delivery, cord clamping, placental delivery, very importantly, hemostasis and closure of the mother, and of course, further resuscitation or stabilization of the delivered baby. These are some images of our Cape Town multidisciplinary team having been fortunate enough to be involved in 2 exit procedures previously. As you can see, our team is also quite large. It also involves a fair amount of equipment, space in the theatre, difficult communication, and also, as you can see, there's a very large amount of drapings and very limited space, so this can obviously be quite a challenge. There are some studies which actually suggest theatre planning layout, as in this image. However, in reality, this very understandably is not always easily achieved. There are major anesthetic considerations. General anesthetic is the technique of choice, and you have to remember that the anesthetic doctor is treating 2 patients, mother and baby, so you need 1 anesthesiologist for each. With regards to maternal considerations, she is at a high risk for aspiration. This is due to increased pressure from the uterus and increased gastric acid production. When she's in the supine position, you can have reduced preload, and thus we need to put her in the left lateral position. Pregnancy inherently has a reduced functional residual capacity, and so she's at quite a high hypoxic risk. So for mother, she requires a rapid sequence induction and immediate intubation. This can be achieved with thiopental, saxamothonium, and fentanyl, and paralysis is usually maintained with vicuronium that's titrated. Fetal considerations, well, we need to remember that the fetal support is entirely dependent on preservation of the utero-placental gaseous exchange. The uterine and umbilical artery blood flow will influence fetal oxygenation. With regard to the uterine artery, that's mostly affected by maternal blood pressure and myometrial tone. So things that influence this are things like our volatile anesthetic agents. So your maternal blood pressure must be maintained within about 10% of the baseline for fetal oxygenation. When we look at umbilical artery flow, that's predominantly influenced by fetal cardiac output and of course your placental vascular resistance. So we have to preserve this cardiac output. Our inhalational agents may cause fetal myocardial depression and result in hemodynamic instability. Additional consideration from an anesthetic perspective, augmentation of this uterine relaxation that we aim for is by a tocolytic agent. It is extremely important to maintain uterine volume as well as to prevent uterine contraction. This is, uterine volume is maintained by preventing complete delivery of the fetus. So we only deliver a head, neck, and possibly 1 arm, sometimes both. And after partial delivery, we then subsequently follow with amnio infusion of warm Ringer's lactate to prevent any cord compression. It's extremely important that there's excellent communication between the surgeon and the anesthetic doctor just before clamping of the cord and ending the exit. we have to try to prevent ongoing uterine atomy and excessive maternal bleeding. So at that point, there needs to be a reduction of the volatile anesthetic and oxytocin administration. You might also consider uterine massage and theta-2 alpha-prostaglandin. And just to mention that our fetal anesthesia is primarily achieved by transplacental passage of volatile anesthetic agents. From a surgical technique, which is probably more in our line of work, we require entry to the abdomen. This can be done by a low transverse skin incision or midline fascial incision. The incision is based primarily on placental location and the predicted site of the hysterotomy. The incision choice, you can have a low transverse abdominal incision unless your placenta is situated very anteriorly, in which case you may need to do a posterior hysterotomy. And if a posterior hysterotomy is required, the patient's going to need a midline laparotomy. Once entering the abdomen, the uterus is examined to see that there's adequate myometrial relaxation. And just before the hysterotomy, once again, we use ultrasound-guided mapping to identify the placental edge. So, as mentioned, the position of the hysterotomy is primarily dictated by this placental location. If there's very severe polyhydramnios, you may need to do an amnioreduction. Amnioreduction is important because if you leave the severe polyhydramnios, it can cause an underestimation of exactly where that placental edge is sitting, which will obviously influence your hysterotomy site. The hysterotomy is done with a very specially designed uterine stapler to reduce bleeding. And we have to maintain uterine volume to prevent cord compression with warm Ringer's lactate. It also reduces the likelihood of uterine contraction and placental abruption. Limited fetal delivery helps maintain uterine volume as well as fetal pressure, temperature. And only the head, neck, and shoulders are exposed. This is an image taken from one of the procedures that our team has been involved in. This is us waiting, as you can see, closer to the screen. Those are two ENT surgeons, and essentially they're waiting for the baby to be partially delivered onto this Mayo tray that's been placed onto the mother's thighs. When we look at the mode of delivery, these are two images where we can see that only the head and neck have been delivered, and baby is still attached to the fetal placenta. And in the image on the right, we have delivered up to the chest. Fetal monitoring shortly after this partial delivery is extremely important. So this is an indication of all the goodies that needs to be attached to the baby. This will include pulse oximetry, IV access, that may even require an A-line, and there's some sterile echocardiography that can happen at the same time, and they also use reflectant pulse oximetry in order to have a reliable reading. When we get to fetal airway management, this is really the most important aspect of this exit procedure. And as such, we have to be prepared for every contingency. So you need a separate airway trolley, and you need some supplies. So supplies from an ENT perspective that we need direct laryngoscopy, Miller 0 and 00 blades. We want armored endotracheal tubes that are of the appropriate size. We want some exchanges. You would want 2.5 or 3 French feeding tubes to administer surfactant after delivery. We would want a rigid bronchoscope, plus or minus your flexible bronchoscope if available. And obviously there needs to be a formal tray for tracheostomy or mass resection if required. So hopefully during fetal airway management, the baby's partially delivered, we do the direct laryngoscopy, intubation is easy, we manage to intubate the child, and our exit procedure is complete. However, so this is what it might look like. Direct laryngoscopy, endotracheal intubation is our first option, and if we succeed, our exit is complete. However, this isn't always possible, and if you are unable to intubate, you may need a few other tricks up your sleeve. And if you are unable to intubate, often it's because there's a compressed trachea or there's a very distorted larynx. And at this point, you may need to proceed to rigid bronchoscopy. So this is just images of flexible and or rigid bronchoscopy that is used in order to facilitate intubation. If your rigid bronchoscopy is not really successful, you might need a few further tricks. And at this point, you can ask your assistant to elevate the mass of the airway. You might consider releasing strap muscles, and you might even consider a retrograde intubation by means of a tracheostomy. In this image, we can see that the mass has actually been lifted up off the airway, and the patient has been successfully intubated, and they are currently confirming the endotracheal tube position. Furthermore, if these techniques don't really help, you obviously have to consider that it may be time to proceed to do formal tracheostomy. This is an image of a tracheostomy performed by our ENC team. So direct laryngoscopy and endotracheal intubation is your first option. If there's distortion of anatomy, you might need flexible or rigid bronchoscopy. The mass effect can often shift your glottis severely from the normal midline position. So what you can do is you can use an armored endotracheal tube that's placed over your bronchoscope or your rigid lens, and that can then be used to carefully be placed to place the endotracheal tube beyond the level of obstruction. If the rigid bronchoscopy fails, you can consider a retrograde intubation. This is where we perform a tracheostomy through limited neck dissection and a Seldinger technique. The endotracheal tube exchanger is passed retrograde until it's seen up in the oropharynx, and then the endotracheal tube is then passed antegrade over the exchanger, and the tracheotomy is repaired. However, if that fails, we may need to consider other options. And in the case of very large neck masses, the traction by the assistant can lift it up off the airway, and that often permits the endotracheal tube to be passed beyond the level of obstruction. If there's very severe compression, you can consider release of trap muscles. But even then, sometimes airway control is still impossible. And at that point, you may need to consider reflection of the mass off the airway, or a section of the mass, just so that you can actually have access to perform a surgical tracheostomy. If you're going to do a tracheostomy, proper positioning of the tracheostomy is extremely important. And the reason for this is that in these giant neck masses, the trachea is actually pulled up and out of the chest because of the extensive neck hyperextension. And you might find that the carina is actually sitting at the thoracic inlet level. So you have to be very careful that you are actually placing the tracheostomy no lower than the second to third tracheal rings. Once you've secured the airway, we think it's prudent to confirm the position of the endotracheal tube or tracheostomy relative to the carina with the flexible bronch if available. Once the airway is secured, we can administer surfactant by the feeding tubes, and the fetus is ventilated by hand. At this point, your umbilical, arterial, and venous catheters can be placed, and obviously the cord is clamped. There needs to be good communication so that once the cord is clamped, there's a good return of uterine tone and proper hemostasis achieved in the mother, and the newborn can be taken to an adjoining ICU or operating room for resuscitation. The duration, so how much time do we have? Well, in general, the fetal gaseous exchange can be supported by exit procedures for up to 60 minutes. Fetal-maternal gaseous exchange can, under very optimal circumstances, even be maintained up to 150 minutes according to some studies, and there are even studies that have shown up to 2.5 hours. There are a few other exit to airway discussion points that are worth mentioning. These are reversal of tracheal occlusion, a brief discussion on some giant neck masses, and as well as chaos. When we look at reversal of tracheal occlusion, this is where the exit procedure was actually developed to manage cases of congenital diaphragmatic hernia, where tracheal clipping was actually required antenatally. In these cases, basically, we needed time for the neck dissection in order to be able to reverse the tracheal occlusion before the baby is delivered. The time was needed for bronchoscopy, taking out these clips and ruling out other airway injury, intubating the patient and giving surfactant. So the lessons that we learned from these reversal of tracheal occlusion procedures were actually allowed us to apply the exit procedure into various other clinical scenarios. In conditions of severe congenital diaphragmatic hernia, these patients have quite significant pulmonary hyperplasia. And as such, sometimes tracheal occlusion plug is implemented. The plug is the acronym for plug the lung until it grows, and this is done at around 26 weeks of gestation. What it involves is a temporary tracheal occluding balloon that's inserted to actually promote prenatal lung growth. So the physiology behind this is that there is entrapped lung fluid as a result of the temporary occluding balloon that results in such stretching of the lung, and the lung grows. So with the tracheal occlusion, this can be occluded until birth or the exit procedure, whichever comes first, and or intrinsic obstruction of the larynx or trachea. Now, there are many causes of extrinsic obstruction, but the two worth really mentioning, which we'll look at a little bit closely, is cervical teratoma and lymphatic malformations. And then obviously there are the causes of intrinsic obstruction, and this is where CHAOS comes in. CHAOS stands for congenital high airway obstruction syndrome, and it really consists of laryngeal pathologies or tracheal pathologies, as such as atresia, stenoses, webs, as well as some cysts. With these giant neck masses, we can often find significant distortion of the anatomy, and this threatens our ability to secure an airway at birth. And as such, it's associated with very high mortality. The deaths are often associated with delay in securing the airway or an inability to ventilate and anoxic brain injury. And by far the most common giant neck masses are lymphatic malformations and cervical teratomas. There are others, as mentioned before, less commonly fetal goiters, as well as hemangiomas, amongst others. So cervical lymphatic malformations, they account for about 5% of benign tumors in infants, and 2/3 of all cases are actually reported in the head and neck. So they present in two ways. Either they present as an isolated lymphatic malformation that's diagnosed at birth in otherwise healthy infants, or they can be detected prenatally in the second trimester. So if they're diagnosed early in gestation, they appear to more commonly arise in the posterior triangle, and those early ones are associated with chromosomal abnormalities in up to 60% of cases. And they can have many other structural anomalies that are associated with high mortality. Whereas those lymphatic malformations that are diagnosed in the third trimester usually located more in the anterior triangle, and they are rarely associated with other chromosomal anomalies. So this helps us in order to risk stratify and helps us in order to adequately patient select which patients will benefit from having an ICSID procedure. Cervical teratomas are rare. There's approximately about 150 congenital cases described. They form about 3% of teratomas in childhood. 5% of these occur in the head and neck region, and they have a mortality of up to 50%. The cervical teratomas are composed of all three germ layers of tissue, with neural tissue being the most common, cartilage, and then respiratory epithelium. And it is thought to originate either from pluripotential germ cells or as a result of an abnormal development of the conjoined twin. They are generally large and very bulky tumors, up to 5 centimeters to 12 centimeters, and they can actually be described as often being greater than the fetal head. So they can extend into the floor of the mouth, they can involve the tongue or even the superior mediastinum, and they can also be associated with congenital anomalies such as trisomy 13 and mandibular hyperplasia. And polyhydramnios is often quite evident up to about 40% of these prenatally diagnosed cervical teratomas, as well as also in your other fetal neck masses. And the polyhydramnios results because there's an obstruction of the fetal esophagus due to the large neck mass. So issues to consider for giant neck masses. Prenatally diagnosed fetal airway, if they're diagnosed prenatally, we need to monitor them very closely for development of hydrops or cardiac decompensation. If you notice they're more than 30 weeks gestation, it's prudent to proceed to an ICSID procedure. The mean gestational age of fetuses that actually undergo ICSID procedures is around 34 weeks, and this is dictated largely by the severity of polyhydramnios, and often these patients go into preterm labor, and as thus don't have the ICSID procedure at term, they have to actually have them slightly earlier. With these giant neck masses, we have to remember that there can be wedging of lungs in the apex of the chest due to that extensive neck hyperextension that we have. And as we mentioned, that trachea can really be pulled up into the neck, so we may underestimate our tracheostomy size. Polyhydramnios as a result of the esophageal compression can also occur. And when there is polyhydramnios, it makes it quite difficult to estimate the placental edge to this in order to give you an indication of where to do the site of the hysterotomy. Some fetal masses can also be caused by quite a big cystic component, so it may be prudent to decompress the mass before the hysterotomy under ultrasound guidance, and that may help you a bit. The other point that we'd like to just have a brief look at is CHAOS syndrome. This is congenital high airway obstruction syndrome. It's really an intrinsic compression or abnormality of the airway. It can be diagnosed prenatally, and this is where you have near complete or complete intrinsic obstruction of the fetal airway. And what this results in is that there's an inability of the lung fluid from the tracheobronchial tree to drain, and this results in high drops. Chaos is also rare. There's only 52 cases reported, but the true incidence may actually be higher because a lot of these cases actually die in utero. The etiologies are laryngeal atresia, laryngeal web, cysts, or even tracheal atresia, but the clinical presentation, regardless of the etiologies, is generally the same. And what we see prenatally is that they often have these bilateral enlarged echogenic lungs. They have big dilated airways, they have flattened inverted diaphragms, and obviously they have the fetal and ascites and non-immune hydrops. It is crucial to evaluate for additional malformations in chaos, example, cardiac anomalies or esophageal atresia, because this will influence whether or not the patient will be a good candidate for an exit procedure. But once the chaos diagnosis has been made, we need to surveil these patients very carefully. An exit procedure in chaos will allow us for adequate control of fetal airway by even a surgical tracheostomy. And once delivered, these infants might even require prolonged ventilation until they can actually have a definitive reconstruction of their airway. So what is the role of fetoscopy? Well, I did a bit of a literature review on fetoscopy, and there are many roles. It's quite a developing field. Some institutions recommend that fetoscopy be used at the time of the exit procedure as a means to assess the airway and to see whether or not an exit procedure is in fact necessary. But we feel that that fetoscopy is not always very reliable to assess a fetal airway. And we feel that perhaps the most useful aspect for fetoscopy in ENT is, as described before, these children with congenital diaphragmatic hernias, where you insert this plug at 28 weeks to enable lung growth. But that will require regular MRI follow-up to make sure that the patient's actually benefiting from it. So we feel that fetoscopy is predominantly an interventional role for the insertion of this plug. There are some concerns with fetoscopy, such as the risk of preterm labor induction, and also the mother may require a general anesthetic or an anesthetic in general. So just some pointers on our institutional practice. We're very fortunate to have some very qualified individuals within our team that have been involved in 2 cases in Cape Town, one in private and one in Red Cross Hospital. We were consulted for another 2 cases, but they actually didn't require any exit procedure. The children were actually fine. But our very experienced consultant has actually been involved in around about another 12 other cases whilst at other institutions, so not specifically at our institution. So we are fortunate that we have experienced personnel within our team. Generally, they get referred to us via the fetal assessment unit, which has a very good congenital cardiac center. But even the referrals are really not common occurrences, and in general, patients requiring exit procedures within themselves are not common occurrences. We feel that we then need to plan, and we do a very extensive review of all associated comorbidities. We have to weigh up risk versus benefit and all the ethical considerations to the mother and the fetus. So in the mother, this might include things like her social circumstances. Will she have availability of resources to bring the child for follow-up if the child should survive? Are there other children at home? We have to discuss, is the risk of anesthetic to the mother a very large risk of bleeding? We have to make sure that there's ongoing psychological support to assist the mother in making this very big decision as to whether or not she wants to go for an exit procedure. We have to really communicate realistic outcomes and expectations of the procedure, and very prudently, we need to be able to have an open discussion about when we as ENTs will decide to actually withdraw from completing and performing the exit procedure. So the team discussion will really run around situations that necessitate withdrawal of care or aborting the exit procedure. For example, discussions need to happen such as, if the child should have an hypoxic rest at the time of partial delivery, you may find that it's best to actually withdraw from the exit procedure, or if there's detachment of the placental wall and the result is hypoxic downtime to the fetus, you might consider withdrawing. So we will really only consider doing an exit procedure where the mother is a good candidate, so she's willing, she understands all the risks, and all the social factors are taken into account, and where the fetus is a good candidate. So there has to be a very clear reversible pathology that can be addressed, even if that be at a later stage, for the child to have a good quality of life. So examples of situations that may not be considered as a good patient selection are if the child has known to have very significant central pathology, if there's irreversible cardiac pathology like a single ventricle, very severe spina bifida, or kidney agenesis, just to mention a few. So we use clinical reasoning. Can we correct this pathology? We use ethical reasoning. Does the benefit actually outweigh the risk to both mother and fetus? And is the exit really worth attempting in this case? Our institutional reasoning, we have to consider we are a resource limited center, so we have to make best use of our resources. We don't feel that if an institution does not have the necessary skill set that this should be attempted at all. There should be adequate post-operative care. There must be a multidisciplinary team. And there have to be supportive facilities going forward for this child, for the rest of this child's life. So we always have to ask, is it necessary? Is it pioneering, or is it experimental? Well, we feel that it is not unreasonable in our context, as long as we have a very well-oiled system is established. So we can use our pediatric airway skills to intervene in a suitable candidate with adequate multidisciplinary support and skill set. So it might be an option that we should be able to offer our patients with correct patient, mother, and fetus selection. And in our setting, when we consider our resources in private, certainly this procedure would have a significant cost to the patient. In the public sector, you would already be using an existing team skill set, but there's the cost of time of this skill set personnel and resources. And in our setting, there's no real added surgical extras because we are using systems that are already in place. But you have to also consider long-term resource use in the management of a child that might have potential HIE. This is just a teratoma case that was done at our center by OOPS procedure. This mom had endometriosis and previous miscarriages. We saw a very large multi-cystic tumor in the neck and polyhydramnios. The mom already had preterm labor contractions at around 29 and 32 weeks. So really this was a potential airway nightmare. Hypoplastic lungs, tracheomalacia, airway distortion, external compression, as well as the fact that the child, essentially the birth weight was 2.5 because the child was premature. This is our, in the image on the left, this is our anesthetic team getting ready for the procedure. And in the image on the right, this is just as the baby is being partially delivered onto the Mayo table. These are our two surgeons. You might recognize some faces, Dr. Shazia here on the left and Dr. Jessica Maguire on the right. And this is once the child had been delivered or partially delivered. This is once the tracheostomy was secured in place, and the image on the right is the child getting some PEEP via the tracheostomy. And this is a separate case of a very large neck mass that patient was intubated and the mass was successfully resected. So you might recognize some friend faces from various institutions, private and government in this image. Prof. Hossart, Jessica Maguire, Shazia Pierre, and some other private ENTs. So the learning points for us from the limited cases that we have done is logistically it's very challenging. It requires a massive team, and the practical implication of the surgical floor plan is actually extremely difficult. There has to be navigation of interdepartmental priorities during the surgery, and we as ENTs really have to establish our role that we want to play with regards to this procedure. We know that neonatologists are excellent at intubating patients, but as ENTs, we really are saying that we have the skill set and we would like to be involved in these procedures where it is appropriate. So really just, we would like to develop better avenues of communication on when to consult and actually get us involved. Thank you very much. Just a special thank you to Dr. Shazia Pierre and Jessica Maguire for use of previously presented material, and for Dr. Pierre for use of photos used in the talk, and these are my references.
Thanks, Louisa, for an excellent presentation and a very good overview. I would just like to remind everyone to post their questions on the chat function or use the raise hand function. And I'm immediately going to give over to Dr. Shazia Pia, if you would like to comment on your first-hand experiences with regards to the exit procedure.
Thanks, Gerrit. Louisa, well done. It was a very comprehensive talk. I think it summed it up really well, and it makes it possible to visualize a unit like this in potentially any hospital. I think with the right resources, both human as well as equipment resources. I think the one thing that we have to accept is that these patients come through, and we have to have a system that we can offer them some solution or none at all. And with the advent of technology and the fact that we're subspecialists, the fact that pediatric ENTs are known to stabilize an airway either endoluminally or externally facilitates us to be able to give this service to our patients. And I think it's also a very good support structure for neonatologists and certainly for people who are delivering complex children. As Louisa rightly put, though, it is very important the patient selection and the criteria one uses, because resources are obviously stretched across many, many disciplines. I think what is really important is what Louisa rightly said is you must be able to know that you're going to manage this condition, because we do tracheostomies for much more complex conditions. We save children for much more complex pathologies. But we have to know that we can reverse or at least treat the condition that we're willing to intervene for. Thanks.
Thanks, Dr. Pierre. We've got one question on the chat group. Louisa, you've presented very nicely that hypertonic uterus is required for exit procedure with only delivering the head and shoulders and torso. So we've got a question from Khalid Samak on how to deal with the occipito anterior position, or much more of a challenge then, how to deal with the fetus in a breech position, and if exit is indicated in a breech.
Okay, thank you, Khalid, for the question. From what I've read, so, you know, when you have an abnormal position, a lot of the time these fetuses, because of their large neck masses, they actually have polyhydramnios. So it is often actually, the obstetricians are actually often able to reposition the child. So if the child isn't breached, because the child's kind of floating in a lot of additional fluid. So I haven't read specifically on the breech, but I know that so it's in essence, external version has been described, but obviously that carries its own risk, for example, cord compression, and that might compromise the fetus. They also have, you know, when they assess it intraoperatively with the ultrasound, and they obviously also then can gauge an impression of what the fetal position is at the time and plan for that. So they may feel that it might benefit better from a midline laparotomy, and they also have described even doing a posterior hysterotomy rather than an anterior hysterotomy if, you know, your placenta is sitting very anterior. So I don't know if that answers your question, but that is just what I have read while preparing for the talk.
Dr. Pierre, do you have any comments on this?
I was just going to say, do you want me to add something? Well, I think if the child is term and if the decision is made to deliver subsequent to intubation, then the obstetrician would turn the baby. The problem is, and the biggest issue with exits and with OOPS, and this is something probably that didn't come through, is at no time must the umbilical cord be compressed, pulled, squashed, or twisted, because that is the heart-lung machine. And so if that does happen, then you're faced with the dilemma of, do you continue or do you clamp and get out? And the reason for that is because then you're risking the child a hypoxic insult. So if they are sure that they can turn the child while preserving and not squashing or twisting or stretching the umbilical cord, you're okay. Because you want, as you know, with any DLTB, direct laryngoscopy intubation, you want to align the child in a position that you can see the cords and intubate sufficiently. You want to do a tracheostomy with the trachea in the midline position as much as possible, because like Louisa said, the right main bronchus comes up with the teratoma. You're going to go into mediastinum if you don't have central structures. So access is key, position is key. They must position the child in a way that you can easily intubate in under 30 seconds. Everything is between 30 seconds and 2 minutes. Imagine you're holding your breath the whole time. And so if somebody is not in a suitable position and they are not able to effectively turn the child, that must be put down at the time of consent and at the time of discussion. If you deliver a child, like in the picture, on a Mayo stand, and if the cord is squashed or pulled or compressed in some way, you count down hypoxic insult and you decide, is this suitable to continue? You don't want to proceed and have a child with hypoxic insult to the brain, because then you're setting that child up for cerebral palsy, HIE. And that's not what the intention for this is. We do not want to save every child. We want to save children that have a chance of a relatively normal life. And mental function, central state is key. Hope that answered it.
Thank you, Dr. Pia. I see we've got no raised hands or any questions on the chat function, but a very big thank you to Kenneth for your comment. He says, a very comprehensive presentation, well delivered, exciting stuff indeed, and congratulations. Thanks, Kenneth. A very good Wednesday to everyone. We look forward to seeing you on Friday morning at 8:30 for rhinology case presentations. Just a reminder to everyone to please let Dr. Nick Gonzalez, Dr. Tassir Din, or myself know about any willingness or any interesting cases you'd like to present on a Friday morning. We welcome all presenters, regional, African and international. You are all welcome. Thanks everyone. Thanks Louisa. Thanks Dr. Pia. And I'll end the meeting now.
You're welcome. Thanks very much.
Thanks.